it well, and she's still acidotic though. All of a sudden you take that away, she's going to become more acidotic because her CO2 is going to go up. She's not going to be able to get rid of the CO2. The CO2 is going to go up, she's going to become more acidotic, and you're not going to be able to bring her back. So you have to, when you start these people, start them at what they were at. She was breathing 24 times a minute, keep her at 24 times a minute, and then slowly wean her down. So, we put her on at 20 times a minute with like a volume of 6, because I don't like the regular volumes. These little people don't need it. She had a peep of 10. And then we started a bicarb drip. We gave her bicarb. We gave her like 4 amps straight of bicarb, and then started a bicarb drip. So she's getting continuous bicarb. And then we were able to kind of wean the ventilator down to 12. All right. So you have an asthmatic. He's 34 years old. History of environmental allergies. He's on his 5th day of his asthma attack. He's been using his MDI, his multi-dose inhaler at home, every 2 hours. And he's not getting relief. You usually use it every 4 to 6. He's using it every 2. And he's not getting relief. So he comes in, he's a little hypertensive. He's definitely, why is he tachycardic? Because what? Albuterol, right? It's a beta agonist, causes you to be tachycardic. So he's tachycardic. His respiratory rate is up because he's short of breath. He is definitely hypoxic at 88%, and only comes up to 95 with 4 liters by nasal cannula. And he's just barely, he's 100.4. So this guy, he appears in mild distress, or acute distress. He's tripoding, he's leaning forward. He's using all the accessory muscles. He's in staccato sentences. Hey, what's going on? I can't breathe. You know, those little staccato 1 or 2 word sentences. His CV is normal, his cardiovascular exam. His chest is greatly diminished. Okay? But he doesn't have any wheezing. Why no wheezing? Okay. Have you blown a whistle before? Okay. What do you have to do to blow a whistle?
Put air out.
You have to put air through it. Severe asthmatics come in not wheezing. That's a worse sign. It means no air is moving through the tight tissue, so there's no wheezing. You can't wheeze if you don't blow. So this poor guy is so tight and so closed down that he doesn't even have any wheezes. And you'll see this, especially throughout the winter, spring. So you're really worried when all you hear is the upper airways, where the air rises, and you hear that little bit of wheezing. That's a real problem. So he's dusky, his fingers are kind of dusky, but there's no true cyanosis, not really, no acral cyanosis. So they take a genius to figure out what's wrong with him. Acute life-threatening asthma. It could also be a pneumonia, a pneumothorax. If he's tall and young and thin and a smoker, maybe he's got a spontaneous pneumothorax. A PE, things like that. Anyway, he gets the usual treatment, Duoneps, steroids, epi, magnesium, and a sub-dissociative dose of ketamine. So we give him some ketamine at a lower dose, instead of like 4 milligrams, 2 milligrams, because it's a bronchodilator. And it kind of chills him out because he's not working as hard. We put him on BiPAP, so he gets some help, but he doesn't do any better. He actually gets worse. So we intubate him with paralytics, paralyze him, and here's the problem with the ventilator. This is why you never want to ventilate somebody with asthma if you can help it. So, this is normal, okay? So you take a breath, you exhale it, you come back to baseline. Unfortunately, when you intubate somebody who's got severe asthma or croup, we talked about earlier, you get breath stacking with AC mode. So I'm ventilating him. He can't breathe anymore, he's tired. I'm going to ventilate him on AC mode with a very low respirations. Because what happens is, what phase is prolonged in asthmatics? Inspiratory or expiratory? Expiratory. They trying to get all that out against resistance. The problem is, if I'm ventilating it 16 times, I give him a pressure, he begins to exhale. I give him another one, and I never come back to my baseline peak. So you get what's called breath stacking. You need to slow it down and increase the I to E ratio, the inspiratory to expiratory, or you have to decrease that, so that the inspiratory time is very short and the expiratory time is very long. So you're giving him time to empty his lungs. If you get this breath stacking, what's going to happen is he's going to get a pneumothorax. You're going to pop an alveoli because that plateau pressure rises and rises and rises. So breath stacking can be a very dangerous thing, and it's a not uncommon problem when you intubate an asthmatic. It's very common. So what's the first rule when anybody on a vent gets in trouble? What's your first rule? Disconnect the vent. Now, as soon as you disconnect the vent, this happens, it happens all the time, we see it. The best time I was working with a doc in Dallas, the guy had just arrested, he had an arrest, right? Because you increase your thoracic pressure, you decrease your venous return, all this kind of stuff. He gets more acidotic. The guy arrested, and the doc pulled him off the vent, and then he leaned on his chest, and you could hear, it must have been 20 or 30 seconds of expiration. He pushed out the air, and the guy just went, like 30 seconds of expiration. He had never been allowed to exhale. He was so tight, so swollen, that he just stacked his breaths for several minutes. And as soon as he did that, as soon as he took off all that interthoracic pressure, the guy got a heart rate back. If you wait too long, they get a pneumothorax. You guys know how to treat a pneumothorax, right? A needle in the chest tube afterwards, right? So I've seen that too. I've seen docs put a chest tube in, or a needle in, because the guy pops a little alveolus, he gets a little blood popped. So you gotta be really careful intubating an asthmatic in terms of breath stacking. Give them plenty of time to exhale. If they arrest, if they become severely hypoxic all of a sudden, if they tank their pressure into nothing, he's hypertensive, he becomes very hypotensive, disconnect the vent and don't do anything. Just wait. Push on it. Wait. And you'll see all those vitals come back. As that interthoracic pressure reduces and you get better venous return, it's much better. So we actually allow some hypercapnia, right? We actually allow their CO2 to build up a little bit by hypoventilating. Don't ventilate them as much, don't breathe off the CO2. It's called permissive hypercapnia. And it's allowed, it's not even expected, so, because we're breathing less. They just need to get that air past those obstructions into the alveolus. The alveolus is fine, it's open, it will be open. So when we adjust the vent, don't try for euboxia. Try to put everybody in a box that's perfect for everybody, that breathes 12 times a minute. Patients don't always fit into a box. You get a severely burned patient. 60% of their body surface is very burned. They're hypotensive and tachycardic. They're barely breathing. Their SpO2 is low, and their ABG. What kind of disturbance is this? It's an acidosis. What kind? So PCO2 is 52. PO2 is 63. And their bicarb is 17. What's their disturbance? Okay, this is a mixed respiratory and metabolic acidosis. This is a mixed disturbance. CO2 is up, bicarb is down, both problems. So remember Hessel, H and H. Bicarb is down, CO2 is up. That's going to give you a much, much lower pH. So they're a mixed metabolic acidosis. What kind of ventilation does this person need then? Severely burned. She's hypoventilatory 8. Yeah, so that's what we would start with. Put her down, put her on AC for the first hour or two, and then allow her or him to wake up and breathe on their own. So start with AC for a few hours, several hours, until you get the metabolic and respiratory acidosis figured out. And then you put them on SIMV, because one of the problems in burns is you get a lot of airway swelling. So then they can wake up and be on their own after that. So there's a line missing, there should be AC there, just like the last one. So you get another ABG. This is 20 minutes after they've been AC ventilated. She's 7.3, 30, 140, and 15. What do you need to do now? What's your problem? So she's still acidotic. Is her PCO2 normal at 30?
It's low.
It's closer, right? It's better than it was. Still, so there's still some slight respiratory acidosis. Is her bicarb normal at 15? No, it's very low. So you have a predominant metabolic acidosis with some respiratory acidosis. So what are you going to do? And her PO2 is 140. So what are we going to do to this patient? So she's going to need IV bicarb, right? I would continue the ventilation. What about that 140? Is that normal for PO2? Normal's 80, right? So what's the problem with that? How do we fix that? Right, super oxygenemia is not a good thing, right? You guys know about that, right? Having too much oxygen in your blood is not a good thing either, right? So we don't want her to stay at a super oxygenated level. So what do we do about that? Decrease the oxygen, FiO2. That FiO2, what's coming out of the wall into her. We always put it at 100% when we start out. Turn the FiO2 down. Turn it down to 60. 60% oxygen, 40% other gases. And that PO2 will come down, right? So hopefully somebody will talk to you about super oxygen therapy. It's not good, right? MIs, you slap oxygen on people that have MIs, has a worse mortality, right? You think that was always part of MONA, put them on oxygen. People with high oxygen levels have worse outcomes. They have venodilation, they have super free radical formation. It's just not good. So we want to get her turned down. All right. Oh, continues to have metabolic acidosis and hyperoxemia. So turn down the respiratory rate, turn down the FiO2, and add a buffer. So add them to the micro. Okay. All right. See, vents are not hard, right? You can breathe harder, faster, or more. It's really simple. You just got to dial it up. Figure out what triggers the vent. Do you need to trigger it and take it away from the patient? Or can the patient breathe on their own? You're just protecting them. It's pretty simple. And then figure out their metabolic disturbance and adjust from there. Do they need to get rid of more CO2? Do they need to hold on to CO2? So, all right, pretty simple, huh? Questions about ventilators? You're allowed to be scared of ventilators. I was scared of ventilators for years. I mean, really. I just called RT and had them come in. Then I decided I was going to learn about ventilators. I actually take care of my own patients. So, they're not hard. Just imagine a big machine that blows air. That's really all it is. You just got to help the patient a little bit. The hardest part is learning the acid-base problems and what they need. All right. Last thing. You guys want to take a break for a minute? 5 minutes? Or are you ready to push on through ours?
Right.
Okay, do it. Go ahead.